So
Okay, now, ladies and gentlemen, we will discuss different clinical case, maybe in French, maybe in English, depending of what are your own. Yes. And I call so Pomme Jouffroy. Everybody know Pomme Jouffroy. And we will ask for different presenter. I don't get presenter then rapporteur. What does it mean? The difference between bit presenter and rapporteur. Yes. Okay, very good. Okay. All right. Alors, on va faire des coupes. Donc, il y a un présentateur et il y a un commentateur. Donc, first of all, Axel Gamelin will present something. He's there. You have your slide. You have some slide, I guess. Yeah. All right, on the laptop. And the first rapporteur is Mr. Riouin. Alexandre will comment the case. Okay, good.
After we can all can discuss the case.
Faut que tu me dises qui fait quoi. Donc, Axel, c'est Alessandro. D'accord. Ok, très bien. Very good.
Non, pas encore. Voilà.
You have to see
C'était marqué PM, mais c'est bon.
Too much people there. Toi, tu vois? Ah, d'accord.
Okay, let's begin. So the first case is a 57-year-old male who was crushed on a construction site by heavy machinery. Polytrauma patient. He had also a right open tibia fibula fracture posterior 3A, received the nail for it, and a pelvic fracture. So that's the initial X-ray that we received, that we were able to take in the emergency room. So there is obviously one or more fractures. What can we say about that? C'est juste, on fait comme ça.
You ask us?
Yes.
To the floor or? To
First,
the floor.
maybe the floor.
You should point somebody.
J'ai entendu T.
Fracture opposite axon. No, it's impossible to conclude just with the AP view. No, it's no.
No,
So
no,
at
but
least we
no,
can
no, but
see that the acetabulum is fractured, but I heard someone saying it's a T. Is that true? Did someone tell T? No? Okay, I've heard
I
it.
would guess it's a T.
Okay.
I'm guessing it's a T.
Okay, do you see anything else?
Have to check there is no early with
Yes.
Yeah. And
Yes.
it could be primary on the confrontable side. So I think there is possible.
Okay. For the workup, do we only rely on standard AP X-ray? Do we want something else? What else? And what about oblique views?
Oblique views, yes.
Why not?
Why it's painful for the patient and unusual now, and it's not necessary to put the patient in the lateral position. And we've discussed this many times, and I think it's this CT scan. It's a good example. No?
That's right, I totally agree. So oblique views are mainly used for the follow-up controls because we don't want to make a CT scan every 6 weeks. It's the only indication to do oblique views, probably.
However, we will use it during the surgery. So
yes.
I recommend to do it
when the patient is asleep, and to record it on your fluoroscopy, because you will have a comparison before and after your surgery. So you need that for the surgery.
Okay, so that's these are some cuts at the level of the acetabulum. Obviously, this part, all the dome, all the roof, the anterior part of the roof, the posterior part of the roof is still attached to the iliosacral joint, so it's the stable fragment. Is it helpful for the classification when we see that? What can it be? What kind of fracture? Still a T, or can it be something else? Can it be associated both column fracture? That's mainly for the audience, no? Everybody agrees? AC, PHT, anterior column, posterior hemitransverse? Neither? Okay. So everybody agrees for T fracture. I try to choose the right incidences, but as you can see, it's really a fracture from the transverse family, and there is a vertical limb inside the ischial tuberosity, so it's a T. Okay. And now about the second fracture. So we saw that there was something at the level of the iliosacral joint on the right side. It's no more obvious.
So we have a dysplasic hinge, lumbosacral hinge first, and we have. Sorry. And we have also literally called impure fracture. We call that Kumar-1 fracture. That means a fracture involving the posterior part of the iliac crest and the sacroiliac joint. A crescent fracture, if you want. Kumar-1. So we have to fix the sacroiliac joint, I guess, but taking in account the dysplasic aspect of the sacral proximal bone.
So everybody agrees?
And on the other side, on the ilioischiatic branch, you have a fracture also. But I don't see a fracture of the iliopubic bone.
It's just
on this reconstruction. Maybe
here.
You have to check. Yeah, there. All right.
It's very tiny, but there is
non-displaced.
a fracture line.
Okay. It's more understandable.
On the 3D, you see the part of the part of the anterior wall. You see on the 3D. You see yes,
Here?
yes.
There is a little bump. Yeah. Okay.
So I guess we have to do two jobs.
Two fractures, two jobs.
Pelvic ring and acetabulum.
So you told us it's LC2 type crescent, and there are two ways of classifying it with using the Aorta classification, depending on which version we use.
We use the
2018.
No, not the. We don't use the AO classification, but more the Day and Kumar classification, which is very interesting because we can, depending of 1, 2, 3 Kumar style.
You choose the way to treat it.
Exactly. That means if you are just in the middle of the sacroiliac joint, is no way to do a fixation. If it's anterior, there is no real sacroiliac disruption, so it's better to do an anterior approach with plate or things like that, or posterior-anterior fixation. by a screw, but and only in CUMAR 3 you have to you may able to do an iliosacral fixation. So I think this classification is nice to decide which way you treat the cruciate fracture.
So
I don't know
really
if
use
you
Can
use it. You use also this cruciate fracture classification.
We use the classification of Martin Bircher.
Bircher.
1, 2, 3, depending is in the upper third, in the middle, and the lower third. More or less is the same. So
Yes, I think it's the same.
Yeah,
Birch,
yeah,
CUMAR
it's
and
the same.
they
Yeah,
are
yeah.
doing the same.
yeah,
It's Bircher?
it is the same. Yeah.
The name for you is Bircher classification?
I think it's the day. I think it's the
Day,
day.
yeah.
Yeah.
Day.
It's the same.
Yeah, it's the
It's the
same.
same.
I think it's the same. Yeah.
In the same sense.
Kumar was the last name and the first name.
Okay.
Ah, yeah.
There's always a Kumar.
Yeah. Okay.
I think what is important for this fracture is just to well analyze the part of the sacroiliac joint which will be injured.
Yes.
If you have
Separate.
a major part, you will have to do a neurosacral screwing,
Yeah.
and if it's more a bony injury, you can do a posterior anterior screwing or anterior posterior screwing.
And what
You
would
have-
you do
have
here?
any view of that?
I don't have all the views.
Okay. Looks like a 3, no? You use the what? The AO classification?
We try to record all our pelvic ring injuries using the AOT classification. And for the acetabular fracture, we use the Judet Le Tourneur. Okay, what can we do now? So 2 fractures, or 2 patterns. What do we treat? Do we treat the acetabular fracture? It's a heavy worker, so still active, displaced. I hope everybody says yes. Okay, good. Do we treat the pelvic ring injury fracture as well? Yes, why?
Because you are in great danger of sacroiliac pain and future sacroiliac pain. It's very painful to have non-well reduced sacroiliac joint.
That's right. It's usually why they are painful at the end.
Also, it's difficult to fix an acetabular
Yeah.
when
No.
everything else is moving
It's
around.
moving,
You need one piece of bone that is like solid, so that you can build onto that.
Yeah.
But sometimes it's possible that it's more easy when everything moves, but after you reduce your teeth fracture and you have displaced your sacroiliac joint, it's not very good. The problem with the acetabular fracture is not like a femur or like a tibia. You have one piece is in place and you have the possibility of move only the part,
Lower part.
the lower part in a T fracture on transverse pure transverse. And it is a problem. And when you have a sacroiliac joint displaced, everything moves. But I think it's not a good thing that everything moves. It's a better solution when you fix your sacroiliac joint and after you operate your teeth fracture is probably the most horrible fracture from the acetabular surgery.
In such a fracture, can you go back to the 3D? It seems that there is some crash of the iliac wing, and therefore a question could be if it has to be reduced and fixed to allow for a better fixation of the acetabulum. So
You're talking about that, or?
About the sacral wing.
Yeah. Maybe it would be an arthrodise fusion.
So this
First.
compression might make the process of the
The reduction of the acetabulum more difficult.
reduction complicated. Because if you want to use both margins of the joint
Yeah.
as the criterion for reduction, then everything will be fixed in internal rotation, and that's no good. And that's why I think that in that case we should begin with acetabular fracture, and then because at least the joint of the hip joint is okay, or should be okay, depending on your skills. but at least you can do a good work on that, and then if the joint is okay, if the anterior pelvis is okay, you don't have to rely on that compression anymore, and you should be able to fix it in place without trying to reduce more than that. That was my meaning. I'm not sure it's the good one, but
question. Do you use to treat that traction table or not? Because also it will make the difference with the posterior part. I think as a perm, I use a traction table. I don't know if you use it for that.
so I was taught without traction table.
So I think it's a different way to treat the fracture too.
Are you talking about lateral traction or longitudinal traction?
Long.
Everything in the same time, depending. We use a traction table, not.
With the foot, tract on the foot.
Yes.
Eventually, not too, but traction table is
The-
reduce it.
The problem is everything, when you have two lesions, it's a reflection. What do you reduce in first, and what kind of installation? Your decision is if you install the patient prone or back, and it's all the reflection is with and with the technique you have in your disposition. If you have an arm and you can put a screw percutaneously, and all this done the decision to the order and to the approach is very important to have. What is the approach for the T fracture? What is your installation? And it's a discussion. What do you use of this installation for your T fracture?
So not for all of them. For this one, it was
Supine?
décubitus dorsal sur le dos.
Supine.
Supine, yeah, not prone, supine. Stopa approach plate.
So we have to move on a little bit
And if
Yep.
into the case.
Yeah. So what? Okay. So we are now talking about the definitive fixation. So it's complicated. It's a long surgery. You do it directly.
We wait for
Like-
5 days.
Okay. What do you do in between?
But we wait reduced.
Okay. So it's important not to leave this joint unreduced. How do you reduce it?
We try the traction.
That's without traction.
Okay, good. That's what we did directly. So now the joint is okay. You can still see that some of the fragments are not at the right place, but the joint is okay. We can wait.
The head is
And also it's easier to interpret the X-ray.
Mm. What do we wait for? What do we wait for?
Hemostasis?
Yes. How do we check it? What can we use? Which criteria can we use to say, okay, now the patient is fit for surgery? It's not too complicated. It won't bleed too much. Is day 1 safe? Day 2 safe? Day 3 safe? It's gonna be an approach inside the abdomen. So we have to wait 4 or 5 days because we know that in the first 3-4 days it might be quite bleedy.
Yeah.
So I think it's better to wait.
Mhm.
I guess everybody agrees, or
Yeah. But before surgery, we do also a control of the iliac vein
Mhm.
to see if the
So with Doppler or
Yes.
venography? Doppler.
to avoid any movement of the clot.
And if there is something, you may use parachute.
yes,
Exactly.
Okay.
in case.
Okay.
We always say that we have to wait 5 days, and I wait
Yeah.
5 days, but it's not because we know that we can do before, because there is no control group with 2,000 patients with operating in the first day and the second day. We, not all of them, but large part of us do not make surgery with intrapelvic approach in the 5 first days, but I think it's an habit, it's really empiric, but it's not
evidence-based.
proof by the, it's not evidence-based medicine.
You're right.
So
No.
just, I don't, yeah, I
C'est
don't
pas-
say that we don't have to do that. I just say that it's not
Alors,
evidence-based
attends,
medicine.
je ne vais pas le dire en anglais parce que je ne vais pas être capable, mais il n'y a pas d'évidence-based medicine, tu as raison. Mais, historiquement, je peux te le dire, le monsieur qui dirigeait le fer à moulin avait été penseur à Garches. Il m'a dit, Madame Jouffroy, quand ils ont commencé d'opérer les fractures du cotyle, ils les ont opérées en urgence, on mettait des caillebotis dans la salle, tellement ça saignait. Un caillebotis, c'est un petit truc en bois pour que tu sois pas dans le sang.
In the shower to avoid.
Tellement ça saignait, ils ont tué les malades, hein. Ils ont tué les malades. Et donc, ils n'ont pas d'évidence-based médecine, mais ils ont dit, on va arrêter de les opérer en urgence, on va attendre 3-4 jours et ça va être moins touchy. Et ils ont arrêté de tuer les malades. Donc, c'est vrai que tu as raison, on peut faire une série comparative avec le nombre de malades qu'on va tuer, mais je suis pas certaine que ce soit une bonne
idée. Je dis
idée.
pas qu'il faut faire ça, j'ai juste que on le fait tous, et moi j'opère jamais en urgence. Voilà. C'est juste de se dire que, parce qu'il y a des gens, on a l'impression que c'est quelque chose qui est largement reconnu, on le fait tous, il faut le faire, moi j'en suis convaincu pour pas tuer les patients, mais c'est juste de savoir que ça repose pas sur des preuves, parce qu'effectivement, pour faire des preuves, il faudrait tuer des patients. Et
Bon, ça c'est une discussion, voilà. Une vraie, on va avancer, Mehdi il a des choses à dire, on en parlera devant le repas tout à l'heure. Est-ce que tu peux clore le cas s'il te plaît pour nous dire ce que tu as fait, parce qu'on en a 2 autres à passer.
To see that the posterior component of the T fracture was quite well aligned, and I did that with a stopper approach at day 5, a little help from a lateral window. I decided not to fix this one, but I fixed this parasymphyseal fracture with a mata plate. I extended a screw inside the posterior column, and that's for the cruciate fracture, so I was quite happy on the x-rays.
So you do posterior, anterior?
Yeah, anterior to posterior, and on the CT scan you see that they are not really crossing the fracture line. But the acetabulum is, I think, quite nicely reduced. And 1 year after the surgery, it was still okay. I had only discomfort on both groins, but you can see that also on the other side there is some osteoarthrosis.
My question is about the fixation of the posterior column, because it seems that the posterior column is fixed only by a single screw outside the plate.
Yeah.
So as there seems that there be some displacement, rotational displacement of the posterior column. Do you think that further fixation, thinking now?
Maybe 2 screws.
Yeah.
Or
Peter, what do you think about
using the distal part of this plate.
Okay. How would you fix the posterior column in this case?
I might have left it alone and then just do my anterior fixation and then just get a CT. Sorry, I probably do my anterior fixation and then get a CT scan and then decide whether the posterior side needed fixing or not. But it's difficult because you want it to get it absolutely perfect. Yeah. It's just. I mean, it's amazing X-ray. It looks really good. It's great. You just wonder how much of a gap or a step there was on the posterior side. So I would do a CT scan after the first one, and if it looked perfect, I'd do what you did and leave it.
It's the advantage to have a 3D control operatively.
Yeah.
If you have the 3D control, you make this reduction anteriorly and you verify your posterior column. And if the posterior column, the T fracture is the indication sometimes to have 2 approaches and return the patient and put a plate on the posterior column if it's necessary. Sometimes it's not necessary, but the control with the O-arm and perioperative is wonderful.
Except
I agree.
that the picture of the O-arm is not only always good for diagnosis. It's good for navigation, but not so. But we have to close this case, I think, because we have two other one. And thank you very much.
Great job.
Yes, you're welcome. So we call now.
Yes, Marie.
We call Marie Le Baron from Marseille, the second time in France, and also Peter Bates, who will yes, come with us, and you will have we will have your comments on that. It's a strange process, but it's okay.
We will continue this discussion with not very different case, but some difference. So recent case report with man who had a road traffic accident alone with accident no other trauma, just no imaginary fire, just fractures. There was complex fracture, right peripheral fracture, right generic surgical leg fracture, and pelvic fracture.
Yes.
With the CT scan reconstruction
You want us to make a comment on that? Yes. Somebody want to describe this fracture, or? It's a what?
First question is CT scan was done without the pelvic binder. Would you agree with that?
Yes.
Everybody agrees with that. So in our hospital, the first thing that we do is to put the pelvic binder. Then we open just for a short time to yeah.
Yes, there is now all of the history of this patient. We have two scans, one with the pelvic fracture made in Aorta Center, another hospital, and there was no hemodynamic failure. And we removed the pelvic fracture in our hospital. And then I do not remember why it was another scan, and this is the one. And we can see the fracture. I will show that it's displaced comparatively with the real scan.
So once we have a strong front fracture on the anterior arch, we have to see where is the posterior lesion. So we know that the sacrospinal ligaments is broken, but we have to know if we are through the alar bone or through the sacroiliac joint on the posterior arch. So we have not the response on this picture. So we ask for transversal like that. Okay. And it's a Dennis 2 or Dennis 1. I didn't get it very well. Fracture. Okay.
T-shaped on the left.
T-shape on the left. So it's a Dennis 2 fracture? Yes? Plus a pertrochanteric fracture. That's a comment?
Just
No,
two
wait.
images of the lesions we described before, and there is a specific description, and there is a transsacral fracture.
Ah, yes. That's right. Ah, but on the both
And
sides.
then the S3, 4, and 5 very displaced,
Okay. So we have to look at the cervical bone. Yes. Because of the bilateral line, we have to look at the sagittal reconstruction And here we have a loss of incidence. That means we have a kyphosis of the sacrum. That means the slope of the sacral plateau is increased. That means in the future, when he will walk, he will have a big lordosis to compensate this increase of the slope. You see? So it's H fracture of the sacrum.
Just one side of the sacrum. Just
I
a
don't
left
think
side.
It's only. I think it's only unilateral on the.
Here
Ah,
you
this,
see,
it,
you have the both sides.
yes.
That
Okay.
means you may have this flexion on the fracture.
It's certainly comminuted distally, but coming out of the top at S1, is that we've only
Just
got one fracture line. So
non-displaced
I'm not sure
incidence.
it's classic spinopelvic.
No.
I think it's like an
Vicious.
it's like an LC1 at the
Vicious.
S1 level, and it goes down to a highly comminuted sacrum from S2 downwards.
So it's a T fracture like
So in this case, we think about reduction of this flexion. See,
Mm.
it's going up.
Even with the subtrapelvic fracture.
Yes.
Oh, you agree.
this fracture.
And we think also that the ilioinguinal ligament is not destroyed. That means if we reduce the symphysis displacement, the ligaments will maintain a certain stability on the iliopubic branch bilaterally. So depending on what we want to do on the posterior part, I don't think we are obliged, but it's my vision, obliged to fix the bilateral iliopubic bone.
Yes.
Maybe we'll do only symphysis, and the traction on ligament will stabilize. What do you think?
The traction of ligament and the perios is
Yes, very thick.
very thick
Yeah.
and permit to don't operate.
What do you think?
Don't fix.
So my priority here would be the subtroch fracture. I must say, the subtrochanteric fracture. So I would go after that first. Personally, I would actually do it because it's almost, there is some comminution, but anteriorly the femoral neck looks like it's two-part. It's not comminuted. So I might do a small approach directly onto the greater trochanter and put a Weber clamp or something on there to get it absolutely perfect, and then do my nailing, as you did.
No, it's not perfect.
You did not
I
perfect?
know, so I will pass.
You never
fast
use
on this.
the hook plate from St. You see the hook plate?
You can just use a trochanteric claw here, but we know that plating of subtroch fractures is not as powerful as nailing. So I would have used a nail, same as you did. I might have gone for a more anatomic approach, like literally visualized it rather than doing it on traction. Normally I do it on traction, but here it was so nice and two-part. You could just go click, and it would have been perfect, and then just nail it.
And you still have the medius gluteus working on the abduction of the proximal part.
Yes.
It's a little bit varus there, but it's a young patient, so it'll probably be okay. Humerus looks lovely.
So we did femur and humerus fracture first, and then how do you manage?
I would like to say something about these fractures when you have bilateral pubic ramus fracture. And pubic symphysis disruption, so you have both injuries. There is the philosophy to say, okay, the ilioinguinal ligament is safe, so I just have to close the pubic symphysis and it will heal, it's right. But if you have a posterior injury and you intend to reduce it by the anterior approach, when you close the pubic symphysis, there is no motion in the posterior part of your pelvic ring because it's moving in your fracture site, so you have a displaced fracture of the pubic ramus. And if you intend to reduce the posterior part by the anterior approach, you have to fix it. That the only cases of, or I will put a screws and then a plate, because I know if I just put a plate on the pubic symphysis, I will just have an opening of the fracture site of the anterior part and no reduction of the posterior part. Here in this case, I agree, it's not necessary, but you have to keep it in mind. If you want to reduce from,
Posterior.
yeah, you have to treat the 3 fractures on the anterior part.
Yeah. So next up, I would do what's easy, and what is easy here is the LC1 through the S1 body. So I would put a transsacral screw, or I tend to use transsacral screws, but many people use just one side, and I'd put that right across S1. It's not a dysmorphic sacrum, so I think that's a safe shot, and then that takes care of the sacral Denis type 2 injury at the back.
Do we need in prone position or in supine position with a big cushion to have a reduction of,
I think this is a comminuted low sacral fracture. So I don't think that your
incidence.
I don't think the incidence will correct. I hear exactly what you're saying, but I don't think. I think that sacrum is smashed, and there's no element of fixation you can get into it that will help you here. I think he's going to have a flat ass for the rest of his life.
Flat ass.
A flat ass. I agree with you that the anterior injury. So that leaves us with those 3 fractures at the front, and I would go after all of them. And I think I would do the one on the right side, because it's a T. You need to. I think it warrants an anterior. I would probably just open it up and click it reduced, and then do an anterior column screw, and then I'd do probably a retrograde column screw on the right, and then put a symphyseal plate on. So it'd be column screw, and plate. You could plate the whole thing, and that is also absolutely fine.
And for G fracture?
And
The posterior part?
okay, for the posterior part, given that I've done an approach to the acetabulum, to the anterior acetabulum, I've done my stopper, so I would go in and then take that. I'll see if I can get that reduced by putting. I usually put a. I would put a hook underneath the lesser. Get a hook into through my stopper. Get a hook into under the lesser notch and pull that up, and see if I can get a nice read here. You can also, it's very low down though, it's very low down, difficult to get to through stopper, but if assuming you can see it, I would try and reduce it, and then you can shoot a PCS or a butt screw, which whatever suits. Butt screw in supine is quite difficult. You have to really flex up to hit the butt screw. So it is easier to do a small approach here and shoot down, I would say. But butt screw does work. But it's easier to do in prone or.
The collinear, if you want to reduce.
Yeah, but if you're using collinear, you either need a middle window or the collinear is difficult. I've found in a stopper. You can do it, but it's really difficult. So I tend not to use it. But collinear is perfect through a middle window. Yeah, it'd be an absolute joy. Yeah, that'd be lovely.
Any other comments?
Not for this case, but in general for the sacral fracture with major kyphosis deformity. What are your indication to spinal cord decompression of the sacrum?
So we expect
Never. Somebody says
expect
never.
a
Somebody
reduction.
Always.
No, never.
No.
Never.
You
Because
never.
we know that when you open the butt, you have
You see everything is broken. So
Yeah, spaghetti
Peter.
everywhere.
just a constatation and doing nothing.
because
But we
there's no
expect-
consensus on the literature about
Yes.
that. Somebody says if you have to do something from posterior, so open.
No.
No consensus.
No, no,
No.
not at all. The only way to remove the compression is to reduce. To reduce by a big lordosis of the sacrum. You push on it.
Yep.
I tracked on it.
And even if you sometimes Sometimes there is comfort. It does not depend on that.
So, Marie, could you move on?
So, I begin by a stopper approach, and
Yes.
first with reduction of the pubic symphysis, but no plating, and extend to stopper on the left side on the anterior column to reduce the anterior part of the T. And after I put the second plaque on the symphysis pubic to synthesize it. Yeah. And I think there is no need to synthesize the pubic rami at the right side because it was no movement.
Pretty stable.
Yes, it was pretty stable.
Any
And
comment on that?
I didn't manage to, by this stopper approach, to have a good reduction of the posterior column. So in a lateral position, I did a Posterior approach to put a plate on the posterior column.
To fix the
And
posterior column.
yes, and after that we do a CT scan, and we saw that the sacrum has no displacement on the S1, and in our team we don't know to manage sacral fracture, so we discuss with neurosurgeon, and they say with us that there is no interest to operate the displaced S2, S3 and sacral fracture, so we stop here.
And to launch a screw or two posterior screws? No?
It would have been a possibility, but in our center we have OARM, but not these days with not disponible. It's organizational consideration because.
Any comments?
It looks really nice. Your reduction looks very good. So I have no criticism of that at all. I would have done it differently, but I guess all I would say is that you've used a super. I'm not against the suprapexneal plate, but I don't think it got you very much here because it's the fracture's here, right? The fracture's there's no fracture from here upwards. So I would say that all this really needs is a plate from here to here to fix a fracture there. And the bit on the quadrilateral surface you didn't use at all, did you? Because you then fixed the posterior side from this side. So I guess, but it's good. Looks good. Looks lovely. I'm not being critical. It's just kind of you start off. You get very used to using implants, don't you?
Yes, we are confident with an implant.
Exactly.
It allows us to make several treatments.
You get to know an implant,
Yes.
and so you feel very comfortable with it.
If you think that your posterior column, the part of the fracture, the posterior part of your fracture is not exactly like you want, it's absolutely necessary to don't put some screws on the posterior column on the anterior approach, and have the possibility to reduce. And it's in your mind when you are in the anterior approach. It's very yes, it's very important. Okay.
It's few CT scan views, and it's a recent case of where I have this way of 3 months after surgery, but I can see that there is a little bone on the patellar fracture, so I hope we.
And no problem with the sacral part of the fracture?
He has pain.
It's painful.
It was painful with.
He broke it.
And a few weeks after surgery. So, but we were very. We give him very low rehabilitation things to
slow.
do. Yes, very slow and rest in bed, and but now he's beginning to walk and it's okay.
Yes. Right. Thank you.
Nice job.
Thank you.
Great job.
So, I ask to Philippe Adam from Strasbourg to come, and Guillaume will be the. You do the comment after the presentation. All right. Yes, yes. Okay. I'm going to take you. Use this one. And this one.
Thank you very much. So you have one lesion of the spine and also a sacral lesion. If we go a bit closer to the pelvis, we have a quite communicated sacral fracture. Obviously, there's not much going on in the front, and at the back, it's a bit worse. So, clinically, she had big scratches on her buttock. She was neurologic. And here is the axial view. Quite a nasty posterior sacral fracture.
And what about the clinical, the neurological status?
She had a paraplegia with an incomplete paraplegia. She had some motor.
Coda equina or paraplegia?
And she had an anal incompetency.
Okay.
But complete monoplegia on the left side, and she had 2 out of 5 in.
So that means you have lesion coming from the spine, and maybe lesion coming from the sacrum.
What was the vertebral? What was the vertebral fracture? Was it L5 or was it?
No, it was L2.
L2. Okay. Has she got quads?
No.
No.
Well, no.
Okay. So there's a sort of cauda equina at L2.
Yeah. Partial.
That means she could improve. It's not the spine.
It's not complete. Yeah. So we have two level lesions. So the problem is how do you proceed? Do we do it in two pieces or in one session or?
First question for Jerome. You try to reduce the kyphosis of the sacrum immediately, as you say that you in normal case, because here it was
here be careful.
L2 fracture.
You have unstable fracture of the spine.
Of the spine,
first.
yes.
So you don't know where is exactly the cord. So we have to look where is the cord, and first of all for us is to fix the fracture of the spine, even percutaneously, depending on that. But usually, because we have difficulties to deal in between the sacrum neurological status or the spinal neurological status, we do a laminectomy on the level above and on the same level to be safe for that. So it's an open procedure. So then we fix it. After all, we work on the sacrum, and that could be only a reduction first, but after having fixed the spine. What's your thought?
I totally agree. I think I would say there is a sense of urgency here. I think with partial neurology, some of that might be correctable. You don't know. So I think we would be taking this probably not at night, but we would prioritize this as first case in the morning, or if it came in during the day, we would do it in the evening.
It was Saturday afternoon, so.
Okay.
During the Six Nations.
I'm sorry.
So we started at 5. So. So in summary, neurological well, if we can classify the community Dennis 3 fracture of the sacrum, hemodynamic stability, which doesn't preclude for emergent treatment. The anesthesiologist was okay for.
But you did the spine first.
No. What we did is we did osteosynthesis in acute setting. We attended for an external reduction, but it didn't work at all. So we did a large incision, increasing the vertical portion, and the curved one on the pelvis to be able to restore a pelvic pillar and bring the sacral roots, on the L2 laminectomy, on the posterior osteosynthesis. We did both with a spine surgeon. When we opened at the sacral area, there was a bulging of the rectum through the fracture. The posterior wall of the rectum was coming up. So we put, we asked the visceral surgeon what to do, and we just put an interface before the reduction. Tried to get both sides together with a Weber clamp, and then did that little plate osteosynthesis with a small fragment on the distal part. And for the large, at the S1 level, we used the U-shaped, U-contoured LCP plate. And then we moved on for the spine fixation. But it was completely moving. It was very, very unstable from top to bottom.
Maybe it was a grade C fracture in Marie-Lannelongue classification, more than a A3.
Yes.
Okay. So you did all in one, and without any variation of the
hemodynamically, we had no.
Because it's a prone position.
Yes.
And the anesthesiologist say okay.
Yes. Yeah, but we were early. She had no other lesion, so that allowed us to do it.
She had a body scan with a check.
Yes.
Check of the.
They didn't come during the OP and say, wait, stop. No, they did not. It was okay. Sometimes you have the radiologist who said, actually, there is something. In the post-operative course, it was not quite so easy. We had difficulties to obtain a psychiatric balance. She had a persecution delirium. On a neurological base, she had a coda ecuna syndrome with a lower limb deficit, which remained incomplete on the right side. She was not worsened after surgery. We had also wound problems with a true infection on wound healing incident that developed at 1 month post-operatively. And we found quite a few bugs inside, treated with debridement and retention of the material on the antibiotic treatment. Then she could be transferred in a rehab facility 6 weeks after the initial trauma. 6 months follow-up, she partially recovers from the post-traumatic paraplegia, but has still persistent motor deficiency, especially on the left dorsiflexors. She can sit and verticalize herself, and has still sphincter complete dysfunction with self-bladder emptying with urethral catheter on the manual discharge of the feces, which is not very nice for a 33 years old woman, and still has perineal hypoesthesia. She's scheduled for L2 corporectomy and bone graft for the spine level to ensure something, and we still hope she gets a bit more bone on her sacrum with the time.
Okay. And the pelvic incidence is not so.
No, the lower.
So much. Not so much.
There's no restoration of the sacrum.
I think your sacrum looks pretty good there. Some people do have a fairly flat sacrum. When she came in, the sacrum was up here, wasn't it? It was displaced outwards. You just pause it there?
Yes, he was.
Pause on that.
Okay.
And pause just.
Pause. Oh. Oh, it's the other way. No, it's in kyphosis, wasn't it?
So Guillaume, you have any comments on this case?
Prepare some slides to cover the case. Just 5 minutes.
So you have 10 to 20 to 15 minutes.
Sorry?
10 to 15 minutes.
Il commente le mien.
Now? 5 minutes?
5 minutes.
It's just to add some comments on the U-shaped sacral fracture, because no, it's not really a course. It's questions we have, because for us it's every time it's a challenge to treat this fracture, and I don't think we have find the right solution to treat them. So it's to give some question and to share this question with you. How to reduce first? How to fix? By which approach, and should we do a laminectomy? For us, we think that, as you described, Jérôme and Mehdi, that the best solution is a close reduction. So you describe a technique with 2 transcondylar traction, I think, but we prefer to use a traction table, but the principle is the same, and put the patient in hyperextension. And with the traction, you can obtain a reduction and perform a percutaneous fixation when you have achieved a reduction. You can perform the control with the arm and then put a navigated iliosacral screw.
What kind of screw do you use?
I will show you after. The problem is the delay to do the reduction. Here you have another example. It's an older patient, but you can see the initial fracture, and we try to apply this technique 3 weeks after the trauma, and you can see the arm control. There was no reduction. We decided to fix this patient in place because it was an old patient, but there is the delay to realize this close reduction is a real question, and I don't know until when you can do it. For the fixation, I think the best solution is the percutaneous iliosacral screw, because there is a lot of mobility. If you have to approach the lesion, it will decrease infection, hardware conflicts when you use the iliosacral screw, but you have to respect some rules. You shouldn't have any comminution of S1. If you have, you can have a good anchorage in S1 when you use a screw, and the transverse fracture should be under S1. Even if not, you will not have a fixation of the spine with the pelvis. So if you have not this condition, you should realize spinopelvic fixation, and you have to discuss the approach. Philippe showed us two approaches combined, but I think with the new device we have and we use for spine deformity, for example, we completely can do spinopelvic fixation with only a vertical incision and fix the patient. But you can see here that when we have to do it, even if you do your best, it's always a challenge to reduce the incidence, and the reduction is never perfect. If you decide to perform only pelvic ring fixation, maybe we should consider a new option to use less bulky devices, and you can use this kind of screw. That's my answer, Jérôme. It's a Euro screw. We can use with in spine deformity, so you can use it alone, but you can use it also with a connector. You will put the screw inside the connector. You can navigate the position of the connector, and you have here another piece of the connector in which you can put a rod to join the two parts of the pelvis if you want, or to do a connection with a spinal construct if you need. And we talked about the problem of laminectomy before. I think the sacrum, it's my advice, but I think you share it maybe. The problem with the sacral laminectomy is that it will really increase the morbidity with the infection problem. It's really bloody. And we know also that there was no recovery after a few days if you have to perform it. So I think it's you should do everything you can to obtain an indirect decompression with the reduction. And if the decompression is incomplete because of partial reduction, it probably means that it's too late to hope for a recovery with a laminectomy, so it's not necessary to do it, I think. And finally, even if you do all your best to treat this patient, I think it's always a long story, and the problem with incidence is not completely done. Thank you.
So, bravo. Could you come back on your last slide? Because my concern about this posterior fixation is loss. My concern about this posterior fixation is lack of lordosis, and it's promoting the kyphosis. So you get in worse. You fix, all right. You fix the spine to the pelvis. That's the first goal. But you lost a lot of lordosis, and then your people are walking like that, you see, and you are obliged to do subtraction.
You can on the A of the shape of the spine.
And you have to do a subtraction surgery, a revision, to rebalance the spine. So I want to share with you the fact that to reduce lately this displacement, it will be better to have a distraction in between the pubic bone there and the promontous there. That means having something, doing like that, pushing the S1 part away from the pubic bone, so you may open the...
And how will you do that?
By doing an anterior approach and having a fancy clamp from... see, you have to design it. Fixing on the front of the promontory.
The problem, it's a nice possibility, concept. But the problem is that in this kind of cases, you have almost you have often a big combination of S1, and you need to have a strong body of S1 to push on it if you want to go via anterior approach. So that's the limit of this concept.
Big limit. I just wanted to share it with you. Sorry.
L5 is stronger, not damaged, and easier to access because S1 is very difficult because of the kyphosis. And you will have the vessels in front of you, but with a transperitoneal approach, it's more easy to see what you do. And L5 easy with the help of digestive surgeon, but you can see L5, and it's the same in the same way. If the connection between L5 and S1 is not disrupted, it means the posterior facet of L5 S1 are intact. Maybe you can reduce. We have to try to do it because it could be a good solution to avoid all of this construction which fails with the time.
One of the common mistakes with this this type of injury is that people hand it over to their spine surgeons. I haven't got a thing about spine surgeons, but if just the spine people treat these fractures, they tend to just fix it in situ. So they just put their plate, their rods down, pedicle, iliac bolt, done, and no reduction, and then you end up with a pelvis that is either very high, or worse still, you have a leg length discrepancy. And we've certainly seen that with people returning from other centres where this was treated purely by the spine team, who don't really do pelvic reduction, they just do spinal fixation.
Yeah, I agree, but even if we know that we have to reduce, we try to develop some technique to put some domino to do distraction between the iliac fixation and the spinal fixation to distract the fracture, and then with the rod in lordosis to recover the lordosis. But even if we do that, at 3 weeks it's a nightmare. It's finished. It's a nightmare. So we don't have the good solution for the moment.
So thank you. Now we have a lunch and back to the room at almost 2.
Yes.
So enjoy.